Good day, people. Welcome to another podcast with Martin Barna. Today's guest is Dr. Marc Surdyka. Hello, Dr. Marc Surdyka. How are you today?
I'm doing well. How are you doing?
I'm well, also, thank you. Dr. Surdyka is a board-certified orthopedic clinician specialist who specializes in the rehabilitation and management of orthopedic and sports conditions across the lifespan. Teaches throughout the Doctor of Physical Therapy curriculum in the hybrid and residential pathways. Dr. Surdyka also serves as a mentor in the Orthopedic Physical Therapy residency and is continually involved in the hybrid immersion experiences. Dr. Surdyka, did I miss anything about you?
Nope, that's it. So yeah, I'm a physical therapist. I do a little bit of teaching and then also have an educational platform with two other physical therapists.
And you have a wonderful Instagram posts and content. I really admire how you can produce very high quality content. And also it is, I think it is very pretty.
Thank you, I appreciate that.
Dr. Surdyka, I have a first question for you. I think you are aware of the spinal flexion myth. I solve it with many clients. Can we have a flexion in our spine, or is it hurtful, or is it not hurtful? How is it in reality?
Yeah, it's a good question. So usually when people are asking about whether or not spinal flexion is bad, they're considering it in relation to probably a squat or a deadlift, right? Some of these heavier compound lifts, maybe people associate it with what is often referred to as a butt wink in the squat. So maybe at the bottom of the squat, you see a little bit of rounding of the low back. So people might call that a butt wink. And a lot of this originated from some kind of mechanistic work by Stuart McGill and others in terms of the idea that spinal flexion is bad, right? And it comes from the work of, like I said, Stuart McGill and others, where they take these part of a pig spine, actually, like the neck of a pig spine, because it actually matches the back of a human spine a little bit better. And they put it in a contraption, and then they kind of bend it back and forth repetitively to see what fails first, like what part of that spine fails first. And it's just the bones, the discs, and the ligaments, like all the muscles are removed. And so what they found in these studies is that, when they do this repetitive bending, like flexing and extending, oftentimes the thing that gives out first is the disc, right? So that was kind of extrapolated to lumbar flexion, or low back flexion is bad. But we can't necessarily perfectly extrapolate that research to deadlifts and squats and other movements for a few reasons. One, no matter how flat or neutral your back looks during a squat or a deadlift, you're going to have lumbar flexion. So when someone says you can't do lumbar flexion, you can't do a squat or deadlift without lumbar flexion. So it's actually impossible to do those movements without lumbar flexion, even if you take a ruler or whatever and the back looks extremely straight. There's still some lumbar flexion happening. And the other thing is, like we're taking these cadaver models. So like I said, it's like a dead pig spine. And we're assuming that the same thing happens in a human, right? But in a human, we're going to expect some adaptation to occur. And we see that with different activities, with rowing, with running, with cycling, is that these discs are adaptable. And they might be, less adaptable than something like muscle tissue that adapts faster, but they're still adaptable. So, the idea that we have to maintain this perfectly neutral spine during these lifts probably isn't the best way to think about it. Now, there is probably still some inherent benefit in trying to, brace and stiffen your core during these movements to maybe minimize the amount of movement that's happening there. But to say that, lumbar flexion is inherently bad isn't helpful, because that idea has also kind of moved into other movements like doing sit-ups, right? Where you're laying on your back and you're doing a sit-up. You know, there's a myth that that's also bad for your back based on that kind of same research of, hey, if you repetitively flex your lumbar spine while doing sit-ups, you know, you're going to have an eventual disc herniation. And so instead, you shouldn't do sit-ups. You should do an isometric hold or a plank. But there's no real research in humans that says, hey, if you do repetitive sit-ups, or hey, if you have some lumbar flexion during these movements, that it's inherently more dangerous than not. So yeah, hopefully that somewhat answers your question. We could talk about it more if you have.
Of course. I have a following question, which kind of look, is there some right form of exercise execution then? You know what I mean? We see powerlifters who does deadlift. Let's say they don't have a technique and they don't get injured, then they do very heavy lifts. And then we see people who, you know, whose form is almost perfect from visual standpoint, of course, and they get injured. You know, is there really anything about the form, or is it just a myth that the form is so important? I mean, against injury or in injury regard?
Yeah, with respect to injury and with respect to pain, and those two might be slightly different, right? Because you can have pain and still perform your lift, so you might not consider yourself injured. But with respect to pain and injury with different lifts, there isn't great research that shows that you have to have a certain lifting technique, whether it's for the squat, the deadlift, bench press, etc., that is going to reduce your risk of injury or, you know, prevent injuries. We know that there's probably certain ways to move weights that makes it better for performance purposes. And that's probably the number one thing that, like you said, power lifters would want to do, is they want to move that weight in the most efficient way possible so they can lift the most amount of weight for their competition, for their totals. But in terms of, you know, injury and pain, that relationship isn't as clear because, you know, pain and injury is really multifactorial, and it doesn't just come down to, you know, technique in a single moment. It might come down to your overall training volume and intensity and frequency and the stress that you had that week and the amount of sleep that you had that day and a whole host of other factors. So maybe in some cases, you know, you could argue that something happened in the technique and it might have contributed, but to say that, you know, there's one best way to squat, deadlift, etc., to reduce your risk of injury or reduce your likelihood of getting pain, there's nothing to suggest that.
So, okay, I've heard also that people have different hip alignments, you know, Asians or northern people, and this affects, of course, how the squat looks. And that it doesn't mean that my squat is not, you know, the perfect squat, that it is bad. And also that I cannot get into the full range of motion and I have some kind of hips. Is it right? Do you know what I mean? I mean, the hip joint.
Yeah, you know, we're all going to have slightly different anatomy and what we would call like anthropometric characteristics, just like our body structure and size. And that's going to affect maybe what type, like it might affect whether someone chooses to do a sumo deadlift versus a conventional deadlift, because like the levers are a little bit better for them and it makes, you know, the lift easier. And so sure, yeah, there's going to be some individual variability there, you know, maybe in certain cultures too, like, you know, if you're used to always, you know, squatting down and sitting down in a squat, like that might look different than, you know, more Western culture. But in terms of like screening for that, I don't know how necessary it is. You know, the easiest thing is, hey, put a bar on your back, squat down, let's see how it looks. How does that feel? You know, okay, let's maybe widen the stance, narrow the stance. In some regards, I think it's probably overblown in terms of, hey, let's try to find the optimal squat stance by checking your range of motion and determining, you know, what kind of hip you have, rather than just, let's try squatting, let's see how it looks, let's see how it feels, and make, you know, micro adjustments from there.
Yeah, perfect. About dysbalances in lifting weights, let's say I see a client and I see that, let's say, right knee is going inwards in the squat, for example. Of course, it could be the reason could be that one leg is longer than the other, of course, for example. But also it could be some disbalance in muscle from, let's say, sitting, etc. If I'm not mistaken, of course. Do you correct it or do you not correct it? And do you correct it in, let's say, competitive powerlifter, for example? You know what I mean? I've heard that there is a higher chance to injure yourself if you correct it wrongly, or, because the body is adjusted for the lift this way.
Yeah, that's a really good question, because the way that somebody moves, lifts, plays sports, has some asymmetries. We have to ask ourselves if those asymmetries is actually what makes them a better lifter or a better, football player or a better athlete, right? And if we try to correct for those asymmetries, would that negatively impact their performance? So when you are considering this, you might consider it on a spectrum in terms of, let's say you're working with the best power lifter in the world, and he has this minor asymmetry in a squat. Are you going to risk trying to change that asymmetry if that's the thing that might have, got him to be the best power lifter in the world? Versus, are you working with a novice lifter? You put them under the bar for the first time and the squat looks a little bit funky. And, maybe you hypothesize that if you, corrected that deviation or that slight asymmetry, it would actually make their lift more efficient and they'd be able to move more weight, then maybe you do that, right? So I definitely think you have to consider the scenario in terms of who you're asking about these asymmetries, but everyone's always going to have some asymmetries. So, that's another thing that you hear about, is that we have to correct all asymmetries, whether it's in strength or range of motion or muscle size. And maybe that's a fine thing that you tried to do in terms of your training program, but we're always going to have some asymmetries. And there's not really anything to suggest, once again, that these minor asymmetries are the reason that you have pain or injury.
Okay. And if we are talking about the deadlift again, or let's say, look, about core exercises. I know there are let's call it physio exercises on the floor, on the overball, etc. And there are, let's say, deadlift and squat. If I'm not mistaken, if client does the deadlift and squat and other exercises in the right manner, bracing himself, the core, etc., it should solve the same problem as the most of the core physio exercises on the overball, etc. Is it right, or am I mistaken? Do you know what I mean? That is it needed for everyone to do these core exercises?
No, I definitely don't think it's needed for everyone to do core exercises. You can consider core exercises like maybe like a bicep curl for some people, in the sense that if you were to do chin-ups and you were to do different types of rows and you were to do other forms of lifting, you probably could still develop your biceps really well. They'd function really well. But maybe if you wanted to, improve their strength and size a little bit, you could add some, isolation movements like curls. In the same regard, if you're doing pull-ups, push-ups, carries, rows, deadlifts, squats, all those kinds of things, like you're probably going to have a pretty strong core, like your abdominals, your low back, your erector spinae, like all those muscles are going to be strong. But if you're let's say maybe you're doing CrossFit and you need to be able to do a toes to bar and you need a little bit more range of motion, you need a little bit more strength in your abs, then, maybe the squat and the deadlift isn't sufficient, right? So like it might be one of those things where depending on your goals, more isolation work would be helpful. Same thing for like a gymnast, right? Like they have to have really strong core, and just doing the deadlift and squat won't be specific enough to their sport. But for the average person, you probably don't need to, do a significant amount of kind of core work. If you do heavy or relatively heavy compound work, a couple days a week, like that's your foundation. And then maybe at the top of that, you could add in some core exercises if you enjoy it or it matches some of your other goals.
That's a great explanation. Thank you. I'm asking because I see many trainers, at least in our country, who work with overweight people, and only thing they do is core exercises for, let's say, 10 lections, and they don't get to some lifting weights. They need some hypertrophy also to lose weight, not just the core. Is it right?
Yeah, because now you're asking about time efficiency, right?
Yeah,
and especially like and like motivation. And so let's say that they're trying to just get this person on a regular exercise program. Mm-hmm. Maybe it's to influence weight loss. Mm-hmm. And if you're only working with that person 2 hours per week, and you're spending an hour of that doing core exercises, right? Like there's better ways to go about that. You're probably going to get more bang for your buck in terms of just like commitment and consistency with the program, overall strength, like maybe some hypertrophy, like you said. So in that regard, yeah, that probably wouldn't be a priority, based on that person's goals.
Yeah. Okay. Thank you. What about herniated discs, bulging discs? I can see that there is more and more studies who shows that not only bulging discs, but also the rotator cuff injuries and tennis elbow, etc. All the things, it looks like for me that it can be solved with physio approach, not only with the surgery. And if you go to the surgery, you still have to rehabilitate and use the physio approach to get strength back. So I can see every time, look, all the time I can see people, they go to surgery, they do not rehabilitate, and then they cannot, let's say, extend their elbow fully because, but there are many people, including my father and me, who had a problem with bulging discs and the rotator cuff. We did not go to the surgery and we are well. So what do you think about it?
Yeah, I think a lot of musculoskeletal conditions, so like you said, a bulging disc, maybe a rotator cuff tear, this golfers or tennis elbow, can improve with what we might consider a conservative approach, meaning not undergoing surgery. So a non-surgical approach. That's absolutely true. But there are, so I'll kind of address the other side of it first. There are some times when surgery is necessary. So let's say somebody does have a herniated disc and they have loss of strength, loss of sensation in their legs. A question that a physical therapist might ask a person working with them is, do you have any problems with your bowel or bladder function? Meaning that, do you have any difficulty using the restroom when you don't mean to? So those are things that can happen, with a herniated disc. So there are times when, if there's like a progressive loss of function or some of these other things that are going on, where surgery might be indicated because we wouldn't want that to get worse. So that would be like the case for a herniated disc. And in the case of like a rotator cuff tear, right, like you said, there's, generally a couple types. So you can have a partial tear or a full thickness tear. And it's kind of exactly what it sounds like. And then you can have it a traumatic tear or a non-traumatic tear. So I don't know, do you ski or snowboard or anything?
I ski.
You ski. Okay. So let's say you're going skiing, you're flying down the mountain, you hit a nice jump, but you fall, you land on your shoulder. You never had any shoulder problems before this. You fall on your shoulder and you hurt your shoulder. That would be traumatic, right? And then you realize, oh man, I can't really use my shoulder. It's not moving very well. You go to the doctor, you get an image, and there's that full thickness tear. Now you could still try to do some form of physical therapy and rehabilitation, but that might be an instance where surgery, would be necessary. Now, a different side of that is, like you said, maybe your father, just over time started developing some shoulder pain, non-traumatic, gets an image, it's partial or a full tear. But there was no event that happened. in those cases, yeah, like rehab is going to be maybe the first line of defense for a lot of issues. And we don't necessarily see that, a certain exercise approach or anything is necessarily better than another. Sometimes these things just get better with time. We call it natural history. So they have a natural history of when they get better. It's kind of like a cold. You get a cold, you're going to expect, I'll probably get better in about a week. So some musculoskeletal issues have that same thing, or what we call regression to the mean, meaning that you have a baseline level of symptoms. Maybe you have no symptoms, right? In your shoulder, you have a little spike in symptoms. Well, if we go back to your mean, the regression to the mean, you're going to go back to your baseline. So sometimes, yeah, these things don't need any approach. And then other times, like you mentioned, maybe if there's a loss of range of motion or strength or whatever else, maybe some specific interventions are helpful to address any deconditioning that might have occurred, secondary to pain, secondary to a decrease in activity, secondary to the surgery, etc.
What about if I have torn my labrum? I hope I used the right word. In a shoulder, there is something like meniscus. They say it is a labrum, at least they call it like this. Look, my doctor once told me that I have torn it. He also checked me, and that I will not be able probably to lift weights like before, and I need a surgery. But I said, oh, I won't go to the surgery. And now, 2 years after that, I just worked out, adjusted my training, but I can still military press 80 kilos. So do you think I could have healed it myself, or is it just that my shoulder, let's say, adapted in some way to compensate it?
Yeah, so that kind of goes back to the other couple of conditions that we talked about, in the sense that if it was more traumatic and you had this significant loss of function, maybe you dislocated your shoulder and along with it, you had a torn labrum, then that might be something that's a little bit higher likelihood that surgery would be necessary. But if you just started to gradually, experience pain and you got an image and it happened to show a torn labrum, then that might not be as likely to need surgery. So across the board, shoulders, back, hips, knees, we're seeing more and more research that a lot of individuals have these changes on imaging. So let's say a labral tear, a disc bulge, a rotator cuff tear, who are asymptomatic, meaning that they have this change on imaging, but they don't have any symptoms. And those changes on imaging are probably going to be more likely as you get older, right? So you're more likely, if you get an x-ray of your spine, to probably show degeneration of your spine when you're 80 as opposed to when you're 30, but you can still be asymptomatic despite those findings. So that's a really important thing to know for a lot of people, is that, hey, you might have a torn labrum on your right side, but you might also have a torn, and that side is symptomatic, so it's painful, but you might also have a torn labrum on your left side and you don't even know it, and it's asymptomatic. So yeah, in those cases of, once again, non-traumatic injuries, pain, things like that, oftentimes the first recommendation would be, let's undergo, some form of rehabilitation, physical therapy, to see if we can get you back to doing what you want to do, get you back to, overhead pressing before considering the surgical route. And a lot of times too, imaging isn't necessary. Like you might come to me, say, hey, I have shoulder pain. I have some limited range of motion, some limited strength. We might still trial 3 to 6 months of physical therapy or rehab before even considering imaging, because if surgery isn't on your radar and you just want to get back to overhead pressing, it might not be necessary for us to get the imaging. And if people don't know this information that we're talking about right now, they might see, I have a labral tear, I have a disc herniation, therefore I need surgery to fix this pathology that this image is showing, which isn't always the case.
Yeah, quick, thank you. Is there any rotator cuff injury prevention or something like that? Or is it just about having the strong muscles and partly genetics, sleep, stress, etc. in the injuries?
Yeah, as far as I know, I don't really know any, injury prevention for the rotator cuff. You'll probably see if you follow any kind of physical therapist, they do a lot of like the banded exercises, internal and external rotation. And those are fine because there's not a lot of muscles that do external rotation of the shoulder. So if you were have your elbow by your side and you brought your hand out to your side, that would be external rotation. So there's not a lot of muscles that actually do that. So the rotator cuff muscles do help. Some of them do help do that. And so they can be fine exercises, but I think some people are led to believe that if they do those exercises, they'll have a quote unquote, bulletproof shoulder. But if your goal is to overhead press, or your goal is to do pull-ups, or your goal is to, do other lifts, you still have to do those. And just doing, a banded internal, external rotation doesn't necessarily prepare you for 15 pull-ups or weighted pull-ups or things like that. So yeah, injury prevention for the rotator cuff, not that I know of. You could always throw in some isolation work if needed, but yeah, I wouldn't be confident in saying that, hey, doing these 3 exercises are going to prevent all injuries.
That was the point. Thank you very much. Okay, what about sciatica treatment? When you have the bulging disc, etc., you have this problem. Is there something we can, let's say, advise to people who are listening? How can they help themselves? Many people are scared to go to physiotherapist or to trainer, etc. So is there something you would advise to them?
Yeah, so for sciatica, so sciatica is kind of a vague term that people use, and it's still used today because we have a big nerve in the back of our leg called the sciatic nerve. So people use the word sciatica to describe symptoms that they experience, down maybe the back of their leg, or pain, or changes in sensation, numbness, tingling. Oftentimes, as you alluded to, those symptoms are more so originating from the lumbar spine. So maybe secondary to a disc herniation. So that, that's one thing to know, is that that's more common than there's often the narrative that you have the piriformis syndrome or whatever else it may be. So it's more common that it's from the lumbar spine. And then in terms of treatment, once again, understanding symptoms, seeing a medical doctor if needed, because if somebody is having changes in sensation, a worsening loss in strength. So something that might happen in some individuals is they don't have the strength to do like a heel raise. So standing on your tiptoes. So that can happen. Or as I mentioned, you have these other symptoms, like you have changes in your bowel and bladder usage. So definitely in some cases, imaging, medical doctor might be more warranted. And in other cases, like I mentioned, there's not a best exercise that we know of for the sciatica or for disc herniations. Oftentimes it's just about finding what works for you, whether that's, walking, doing some general physical activity. But in most cases, it's not something to be, overly worried about. Oftentimes it does get better on its own. And we didn't mention that these disc herniations can heal on their own too. All right. So you might get an MRI and you show that you have a disc herniation. You get an MRI again a year later, and that disc herniation is gone all on its own, right? Because it healed. So those are things that can heal as well. But yeah, usually I just try to tell people to try to, keep somewhat active. I'm a big fan of walking. And otherwise, people are pretty good about finding what works for them. But, I think the most common approaches would be one, like the core stability approach, where you're doing planks, side planks, bird dogs. Those are fine. If they work for you, you like them, no problem, not a magic bullet. Another one is like nerve glides, if you ever heard of that. The same thing, can be fine. Some people find them really aggravating, not a magic bullet. And then the other one would be what might be called like a extension-based approach, or a McKenzie approach, where you're kind of extending your low back either in standing or on your stomach. And I'm simplifying it. And if that works for you, great. but same thing, it's not going to work across the board for all people. So, some of it's about finding what works for, that specific individual.
So again, it is individual work.
Yeah.
About ACL surgeries, physio approach, I guess it will be the same as we discussed before. There are some cases when you need surgery, and there are some cases probably you can rehabilitate it on your own or with a physical therapist. Is it right?
Yeah. So generally, after someone tears their ACL or has a full rupture of their ACL, you're looking to reduce the swelling, regain range of motion, kind of test out that side-to-side strength. And we're trying to find if the person might be a coper. So a coper is somebody who can function without their ACL. They don't have any instability of their knee. And, we want to know what that person wants to get back to. So my best friend a couple of years ago tore his ACL playing recreational basketball at the park or something. And he asked me if he should get the surgery. And I asked him how he was feeling, how his rehab was going, what his goals were. And he didn't have goals to even go back to playing basketball, any kind of pivoting sports, soccer, football, etc. So I recommended that he probably didn't need to get the surgery. As most friends and family members do, didn't listen to me, didn't take my advice. He got the surgery, and I think his knee is fine. But yeah, he hasn't done any activities that would require a lot of pivoting or what the ACL assists with. Versus maybe you have a top football player and they need to get back to those high level pivoting sports. Maybe that's a little bit more likely. Or you tear your ACL and you want to go the non-surgical route, but you're having episodes of instability where your knee is just kind of giving out on you. Then once again you might be at a higher likelihood for maybe getting that surgery. But yeah, across the board, surgery isn't needed for ACL like we once thought. So there are instances where you could be fine without the surgery.
And also in case of the ACL, is there some prevention exercise? The same thing like with the question before, or is it again about being strong and not injure yourself in any regard?
There's some injury prevention warm-up routines, like the FIFA 11 plus. And what they do is there's a variety of exercises. They do hamstring exercises and squat exercises and running and jumping and hopping, and yeah, for let's say once again a soccer player or a football player who's trying to reduce their risk of an ACL tear, it's probably just a matter of having a nice comprehensive program, right? Like there's probably not going to be one exercise, but getting your body prepared for whatever the sport is that you're going to do.
Thank you. Look, I have a client. He had a injury at Krav Maga. He injured his knee. He somehow fell, and I will just briefly say that his doctor, he had some surgery, of course, and his doctor told him, well, Thomas, you have no cartilage. You know what I mean? Yeah, and you will not be able to squat again or anything. It is 5 months after the operation. We work out together, and let's say yesterday he did 12 squats, full squats with the bar, and had it didn't hurt anyhow. He said he has full range of motion. Again, should we continue from your point of view to exercise it, or should we don't do it? Because I know what doctor said, but he obviously can't do it, and I want to just discuss the approach.
Yeah. So don't take this as medical advice, because obviously
I know it's online.
I haven't seen this client. I think it's become less common, but it was more common previously for medical doctors or surgeons to tell, patients to stop squatting, stop running. It's bad for the knees. You have bone on bone, you're missing some cartilage. But yeah, I think in a lot of cases, just taking it on a case-by-case basis and seeing how the patient responds, or the client responds. That's usually the easiest thing you can do for, any exercise or condition is, okay, you had this knee issue. Let's see how the squat feels. The squat feels great. That's it, right? It doesn't have to be much more complicated than that. Same thing would be for, okay, you had a disc herniation. We'll try the deadlift. Deadlift feels fine. Okay. So usually it's just, how is the patient responding in that moment? How are they responding the next day? Things are going well, let's continue with it. But yeah, sometimes you would hear, hey, you can't squat at all. And then you would ask, well, how do they get down to the toilet? How do they sit in a chair? How do they, sit on a couch? So
yeah, it's
hopefully that answers your question.
Yeah, of course. Thank you. It is something like when they see then your knee cannot go forward from your toes. When you squat, then how can you go up the stairs if it was the reality? Okay, are there some best sleeping positions, or it doesn't matter how you sleep?
Whatever gets you the most sleep each night, or the most uninterrupted sleep. So definitely that's a common thing that you'll find on Instagram or YouTube is, hey, these are the best sleeping positions for your neck, for your back, or you have to sleep in neutral. And none of that's based on any kind of evidence. One, it's impossible to sleep in neutral. Like, it's just, no matter what you do, no matter how many pillows or you put under your legs or under your side, it's just not going to be possible to keep your spine completely straight. Nobody stays in the same sleep position all night. Even if you fall asleep in that position and you wake up in that position, I promise you, unless you've been up for 48 hours straight and you're just like knocked out, you're not going to stay in the best or in that same sleep position. So yeah, the best sleep position is whichever one is most comfortable for you, allows you to get the most uninterrupted sleep. And that's just one factor, right? Like, you have to consider all of the other factors throughout the day too, in terms of like, are you getting some sun exposure? Are you exercising regularly? Are you trying to minimize your phone usage before bed? Are you, cutting your caffeine 6 to 8 hours before bed? Are you minimizing your maybe alcohol intake before bed? So like, all of those things too are going to contribute to your sleep quantity and quality. But yeah, no best sleep position.
Thank you. Look, are there any tips you would give people that are after injury or after surgery, let's say after surgery, to get better as soon as possible? I mean, in general.
Yeah, I think everything that people probably already know, and some things are out of your control, but smoking can delay the healing process. So, not smoking before a surgery, after a surgery, trying to minimize stress to the best of your ability, trying to get adequate sleep for you. It might vary. Some people might do fine with 7 hours. Other people might need 9 hours. Generally, varied, nutritious diet, regular exercise. That's a big one, actually. So people don't understand that. I'm a big fan of just general like aerobic exercise. So let's say you had your shoulder surgery. I would even recommend, hey, go for a walk, right? Like, ride your bike, like do little things like that. Anything that you can to improve your overall health is probably going to, increase the chance of that healing, a little bit better for like after a surgery.
And what about not ignoring the advice of physical therapists to work on those exercises at home also? You know what I mean?
I don't. What do you mean?
Look, many people go to surgery, and then they go to you, let's say, and you will tell them, do this exercise at home also, okay? And next time we will see each other, and they just don't do it. They don't work out on, on the knee, let's say, on the hamstring, etc. It is not a good, right?
Yeah, like in terms of the healing, whatever that surgery was, it's probably still going to heal fine. But in terms of restoring your range of motion, your strength, unless you're actually training those things, it's probably not going to just come back on its own. So let's say you did have your right shoulder surgery, if you don't try to improve your shoulder flexion, your shoulder external rotation, your strength doing these different movements, you might notice that, it becomes a little bit stiff, or you're not as strong as you once were. So yeah, definitely trying to regain that range of motion and strength as quick as possible within the, guidelines of the post-surgical precautions.
I'm asking because my friend, he had a elbow surgery, and he just did not work on those things that he had to do. He ignored the physical therapist. He didn't go there, etc. And now he cannot extend his elbow fully. And is there a way, let's say it's 2 years, 3 years after the surgery, can he rehabilitate now, or is it too late and he cannot do anything with that? What do you think?
I'd like to think that there's, always a possibility, but it's much easier immediately after, when it's still healing. There are probably some instances where that window closes, or you have to just work way harder than you would have had to if you had done it immediately. But yeah, like after a knee surgery, after an elbow surgery, generally you're trying to regain that flexion and extension back, as quickly as possible. And if you do that, then great. And if you don't, or you just ignore it, then yeah, maybe as you're seeing in your friend, it can be very challenging to get that back.
Yeah, but he should not lose hope, right? And try to solve it.
Well, depends, right? Like, so if he is, now seeing a physical therapist, or he is working on it and he's been working on it for 3 months, 6 months, a year, and he's not seen any improvements, and, that's something that he does want to regain because he needs it for whatever his goals or function require, that could be a discussion to be had with his previous surgeon, in case there is something actually, mechanically blocking that range of motion now. So like I said, I'm a hopeful in a lot of instances, but there are some cases where, that window might have closed because of other reasons.
Thank you. If you can, could you give us some insight on your hip replacement surgery? I think it is a very good example, because like you've mentioned on your Instagram, many people think when they have a surgery, they cannot do sports in the same way than before. But I saw what you can do with your body, also your symmetry of your legs, and I don't see any problem there. How could you do that? How is it possible?
Yeah, so I had a total hip replacement a little over 12 years ago. So I had to take 3 years of steroids for a different health condition, non-musculoskeletal health condition. And those high doses of steroids led to a condition known as avascular necrosis. So it's just kind of death of the hip bone there. And, my only option, because of how progressive it became, was a hip replacement. And yeah, so I still, walk my dogs every day. I ride a bike every day. I lift weights most days of the week. Here in the United States, we just had Thanksgiving, which is, a big American holiday. And I would do what's called like a turkey bowl, where you play sports. So I was able to play some football, football for you, soccer for us.
Yeah.
So yeah, the body is a lot more capable and adaptable and resilient than people think. And that's kind of, the message that I'm always trying to get out there. Now, there's still going to be limitations. Like, I'm not careless with what I do. And I, don't do as much as I did in my 20s. But, I'm still able to accomplish quite a lot, and probably exceeds the expectations of what a lot of people think are possible with a total hip replacement.
Was this a reason you started to study the physiotherapy?
So I actually had a really good experience with the physical therapist in the hospital. So I had the hip replacement, and then a physical therapist comes, gets you out of bed, walks you up and down the hallways, helps you, walk up and down stairs. I really liked her. She made me feel good. So I wanted to, share that feeling with others. So I was in college at the time. So I was studying business, and then I changed it to kinesiology. And then from kinesiology, I went on to graduate school.
Mm-hmm. I think you're doing a great work in spreading this message, that you can get better. And really thank you for your Instagram content and generally for information you share. Okay, one last thing which I ask everyone who is here on the podcast is there, if you could give just one advice to population, what would you say to them? What would you recommend to those people?
One
Anything.
advice?
Yeah,
Anything.
I know it's bad. It is just one, but
that's a good one. I would say like maybe consistency and persistence is key in any aspect of life, right?
Yeah.
So I'm on Instagram. You see like, oh, this guy's got a lot of followers. I've been doing it for 6 years, right? I'm on YouTube. Oh, he has a certain amount of followers. I put in a lot of hours. Or hey, your legs look fit even though you have a hip replacement. I've had the hip replacement for 12 years. The first few years were really challenging. I didn't necessarily know how to go about that process. So it took me a while to figure that out. So, regardless of, what you want to do, whether you want to post content on social media or you're recovering from rehabilitation or you have performance and aesthetic goals, persistence, consistency, and, some things just take time. So being patient with the process.
Perfect. If let's say people listen to this and they want to follow you, get any content you have outside. So you have YouTube, Dr. Surdyka, and also you have Instagram. Again, they will find it by Dr. Surdyka, and I will of course mention the link below. Is there anything else when they can contact you, follow you, or anything I didn't mention?
No, those are probably the two main places is
YouTube and Instagram.
And then YouTube, it's a shared kind of YouTube with 2 other physical therapists. So it's called E3 Rehab. Oh. And a lot of the topics that we talked about today. So the lumbar flexion, the ACL, my hip replacement, all of that can be found there in a little bit more maybe depth.
Okay, thank you very much. Is there anything I didn't mention you would like to say?
No, I think we covered everything. If people have any questions, I'm pretty good about responding to emails or DMs. So feel free to shoot me an email or DM.
Yeah, I have to say that I really didn't expect you replying on your Instagram to my message. And I'm really, really grateful you did. I really appreciate your time spending here. And thank you. You came, and have a fine day.
Thank you. I appreciate your time, and I'm thankful for the invitation as well.
Bye, Dr. Surdyka. Have a fine evening.